Welcome to the Community Care Smart Assistive Technology Collaborative webinar. Before we begin, I would like to acknowledge the traditional owners of the land in which we are meeting today. We pay our respects to all elders past, present and emerging. My name is Georgina Gould. I'm the Business Manager at Global Community Resourcing, and I will be moderating the Community Care Smart Assistive Technology Collaborative webinar today, which focuses on the role of data standardization in aged care. Before we start today, allow me to go over a few housekeeping points. Our webinar today is being recorded. Questions from today's webinar have been taken from the Community Care Smart Assistive Technology Collaborative. If you have any questions after listening to this recording, please email us at sat@communityresourcing.com.au. Our webinar today is being hosted by Global Community Resourcing for our online platform, the Community Care Smart Assistive Technology Collaborative. The purpose of the collaborative is to promote the use of smart assistive technology in service provision and delivery throughout Australia and the world. We have been fortunate to work on a wide range of local, national and international projects with researchers from across the globe to share and create innovative ideas in community care settings. Our webinars are created based on feedback and requests that we have received through the collaborative, and we aim to connect diverse perspectives in research and development, as well as creation and deployment in assistive technology in the community care sector. We are proud to have more than 70 free webinars, which have gathered over 10,000 views on our YouTube channel. Just a reminder that if you haven't formally registered at the collaborative site, it is accessible to all and free to register. A range of resources, news articles, and collaboration opportunities are regularly uploaded to the platform, and you can visit www.satcommunity.com to become a member today. Please note that Global Community Resourcing or the Community Care Smart Assistive Technology Collaborative is not promoting or endorsing any particular product, research entity or organisation. The purpose of our webinars is to serve and inform viewers of various smart assistive technologies and innovations currently in development and/or deployment. In today's webinar, our guest speaker, Professor Len Gray, will explore the role of data standardization in aged care and how we make it a reality. Professor Len Gray is a senior researcher and professor in Geriatric Medicine at the University of Queensland. He is an experienced health administrator, clinician, and researcher. He is the Australian coordinator for Interact, which has developed the world's most widely used assessment and decision support systems for aged care. Recently, he has contributed to the development of Australian star ratings and quality indicator programs for aged care programs. Welcome, Professor Gray, to the Community Care Smart Assistive Technology Collaborative. Please take it away.
Thank you, Georgie, and thank you, everyone involved in your organisation for inviting me to come along here and talk about what I think is a very important subject about data standardization in aged care. And I'm going to talk about the challenges of making data standardization a reality. So I'll now turn on my slides. Okay. So this, there was a time, I guess, when I was a young clinician and seeing patients and dealing with some of the kind of problems with families and so forth that you see in aged care, you would think data standardization, man, that's boring. What's that got to do with reality? Well, I'm hoping in this talk that I can show you how important this issue is, how many challenges there are to kind of sort it out, and perhaps give some suggestions about how we might go forward. I want to say that the talk has an Australian orientation, but the lessons here are really relevant to any modern jurisdiction that is trying to use computers, data, and so forth to improve the care of older people, whether it be in a community or institutional setting. So, why do we even write things down? Well, one reason is, and I think any of you that are involved with older people in a care situation would write things down so that the next time you see them, you can remember what the interaction was last time and what the information was that you gathered. So the obvious thing is record stuff so that later you can access the information, because one's brain can only retain so much. Secondly, one records information so that it can be communicated to others. So particularly in aged care, there's often multiple people involved in the care of a person, and these may be within one organisation. Let's say in an aged care residential setting, there are staff on different shifts. They don't necessarily have an opportunity to talk to each other about everything. So therefore, if material is written down, they can read it, and this supports continuity of care within an organisation. But also, if people are in a shared caring setting where, like, there's two organisations looking after the needs of a particular person, they can send information to each other in a written format through computers or whatever. So there's communication either within an organisation or in a shared care environment, but also if there is a handover of care. So if a person lives in a residential care facility and goes to hospital, then the information can be dispatched with the person so that there's readily available, accurate information at the hospital. And you can think of all sorts of scenarios, and we'll talk more about this later, where shared information becomes really important. Then if information is written down in some way, particularly if it's written in a kind of standardized format, then it can be used for decision support. And what I mean by this is using data to reinforce or advise care decisions. So obvious things that many of you know about are, for example, how can you calculate the risk of someone getting a pressure injury, or the risk of having a fall, or the probability that someone has dementia, or that they may be malnourished, or that they are at risk of requiring institutional care. These are all research-based decision support tools that help assessors, care providers, make more targeted decisions. In other words, they support the right actions for the right people at the right time. So we call that decision support. And finally, information, care-related information is needed for regulatory purposes. If there's a fundor, it may be a private organisation arranging care. They might be buying support from staff or from another organisation. They need to know who the person is that's getting the care and what their care needs are. And by knowing that, they'll be able to monitor, perhaps support payment. So more complex people get more financial support. Also for calculation of quality measures, so monitoring the quality of the service. And also the regulator also needs to know who's getting care, is it changing over time, and so forth. So there's loads of reasons to record information. And it may seem obvious to you, but I think you have to think this through when you decide how you're going to record that information. So the obvious response to how you record information is to try and do it in a standardized way, so that when you record a phenomenon like, say, bladder incontinence, that it's written down more or less in the same manner, regardless of who is doing the writing. And so typically this might be written in open text. The person is incontinent at night, okay during the day, that kind of thing. But that's not going to lend itself to computerization. Then it has to be written in a more structured way for a computer to understand it. So it may be person is incontinent occasionally, quite often, very often, continuously, some kind of scaling or something that tells you something about how often the person's incontinent, for example. So if you have a structured item like that, that then generates the opportunity for a common language, so that when that phenomenon is the information about that phenomenon is shared between two organisations or amongst staff, everybody knows exactly what the continence item is about, rather than having it in an open text or everybody using a different kind of way of doing it. Second reason to standardise is for efficiency purposes. So when you're training people, for example, if they know how to record information a particular way, then it will, and they move from one organisation or they read reports from another organisation, they'll know how to interpret that information efficiently. They only have to be trained once. And that's not the common situation in many jurisdictions, including in Australia. So again, I've already referred to the idea that if you train people about how to record information, they do it one way, they do it the same way, no matter where the person is getting their care, then it does make the training a lot more simple. I've already talked about analytics and decision support. You do need structured, standardised information in order for computers to make best use of it. Computers can read text, but usually the open text, the standard writing, doesn't provide the kind of detail that enables it to be turned into a kind of a format that's useful for decision support. Information exchange between organisations I've referred to, regulatory reporting, again, I've mentioned, and of course data for research purposes does need to be structured, and research, whilst it's not vital to day-to-day care, in the longer term, research is the way in which we find better ways to do things and create improvements. So lots of reasons to standardise the way we record each piece of information. And that then begs the question about why not compile information into a standardised assessment approach so that for an individual in a care setting, the information around all of the phenomena that are relevant to that setting are recorded in a standard framework. So not only is the data standardised, but the whole assessment is standardised. And the rationale for doing this pretty much is the same as the reason why you'd standardise the data elements themselves. So there's a good argument for standardising both the data and the whole assessment. So this is the various ingredients of a medical record that are recognised in the International Patient Summary. And amongst these phenomena, you see, what the International Patient Summary says is that if you look at the red boxes, the things that are kind of mandatory in every record should be a medication summary, allergies and intolerances, and a problem list. And things that are recommended, you should really see in a standardised record, things like immunisations and diagnostic results. And then they talk about optional information, and things that catch my eye when I look at this are things like functional status, social history, plan of care, advanced directives, all regarded as optional. But the one that really stands out when you think about aged care is functional status. How is this person functioning? What are their needs? What help do they need? This kind of thing is really why we run aged care programs. It's not about the diagnosis. It's not about their allergies and so forth, although they're all important. But whilst this is regarded in this framework as optional, I would argue that this component is actually required and is central to the records in an aged care program. Function or dysfunction is why people require aged care. And of course, things like the social history, plan of care and advanced directives all are really things that you should have a good grasp of in these kind of programs. So thinking about functional status, and I use that term broadly, when one assesses and tries to work out what care someone needs, you'll be thinking about, well, what activities does this person have difficulty with? So is it with personal activities of daily living, like walking or dressing, so forth? What kind of help do they need? How much of it? If a person has difficulty walking, is it just a matter of providing them with a walking stick, or do they need a wheelchair, or does someone have to stand next to them and watch them, or do they need two people to kind of support them because their balance is so poor? So that's a matter of how much help the person needs. And then, of course, it's very important to know who is available to provide the help. So in a home care setting, is there someone there that would be able to assist, like a family member, or is it external services, and so forth? So all of those things are really critical pieces of information that help to design and operate an aged care program. And up in the boxes up the top, I've kind of listed, it's not a complete list, the sort of things that should sit inside an assessment that you would want to know about if you were trying to assist a person who had problems with their function and other things. So it's not just about ADLs, left-hand box, or instrumental ADLs, the kind of middle box, but also about what the strength of their relationships are with various people, what activities, what's their life like, what do they want to do, what sort of services can they access, what's their housing like, is it accessible, is it comfortable, is it well heated, do they have any financial resources to sustain themselves, and what about their carer, and does their carer have needs that we have to take into account as well? So there's a lot of information that is needed to design care and to monitor, and these ingredients should sit within a standardised assessment, and they should be described in a way that meets the standard that we talked about a couple of slides ago. So if we think about the world of standardized data, let's think about how we would describe all these phenomena. In terms of an assessment system, you would compile an assessment system using standardized data. You don't use every element that exists, but you would decide which data elements are needed for an assessment system for a particular context. And then within that set of data, many jurisdictions have what they describe as a minimum data set, absolutely critical, important information, typically the information the regulator wants in order to manage the program from a central bureaucracy point of view. So that would be information that supports payment, case mix in other words, information in relation to quality monitoring, and information that supports planning of the system. So thinking about those kind of three layers of data, for decision support, really, we're talking here about care planning, system planning, resource allocation, QI calculation at a local level, and also at a regulator level. So providers themselves, let's think about an organisation running a nursing home, for example, or a community care program. This kind of information is kind of vital for operating the program efficiently and effectively. And the regulator doesn't need the same level of depth of information, but does require some data for the purposes I've just described. So I'm thinking about here a kind of world of data and who needs what when. So what is out there in terms of standardized data? And if you talk to hospital folks, they'll talk to you about SNOMED CT, which is what's called the terminology standard. So SNOMED really is born out of the kind of diagnostic paradigm. So where you've got every disease has a code, a name and a code, and every symptom and clinical sign has a type of a code, And if you record the information using the SNOMED framework, everything has a code, and then that becomes available for decision support and for reporting, for example. So it's been developed mostly in the hospital sector, and SNOMED is the, if you like, the terminology standard that's used in Australian hospitals and in many other countries. And the challenge there is to get clinicians to record information real time as they're doing their work using SNOMED. There's no point having it all coded after the person leaves the hospital, because you actually want what we call real-time decision support. So once I've done my admission assessment, the computer goes to work and makes suggestions about how the care should be delivered. So it would identify risks and so forth. So the trouble with SNOMED CT, it doesn't really deal with the functional information that I talked about earlier particularly well. It doesn't have little scales of telling you how bad the incontinence is, or how much help a person needs to get dressed and so forth. It says things like, oh yeah, the person's got a continence problem, but it doesn't tell you how often. And so we need something different. You may be aware of the International Classification of Function, which is similar to the International Classification of Diseases. It's a very elaborate and well thought through way of classifying disability-like problems. The trouble is it needs coders, and it's really has to be done after an episode of care. And that's not very helpful for day-to-day care, because you need specialist coders. So what is there out there? There's not really anything that really meets what I would call a terminology standard for the kind of phenomena that we care about in aged care. So what are we going to do about that? Before I talk about the solution, I just wanted to illustrate some of the problems we have here in Australia when it comes to data and standardization or lack thereof. So we've done some thinking about this and had a look at a journey that perhaps an older person might undertake if they were living at home and they ran into problems that probably meant they needed to live in a residential aged care facility. You could draw the same map for someone who needed complex community care, but in this instance, in Australia, you or your relative could get onto the My Aged Care website, and where one would be asked to complete a self-assessment, which is essentially an ADL, an instrumental ADL assessment. Quite a nice framework. It's done in a particular way, and that then becomes available for the eligibility services, which in Australia is the Aged Care Assessment Service, that would then use that information and then conduct usually an in-person comprehensive assessment to determine whether a person is eligible for, let's say, for a residential aged care program. So as of yesterday, the aged care assessment team use a new assessment protocol called the Integrated Assessment Tool. It's a very large and quite sophisticated system. It consists of a whole suite of scales and assessment modules that then are put together for assessment. So that is a relatively new innovation here in Australia. On entry, let's assume that the person is considered to be eligible for residential care. On entry to care, they will have a further assessment by the admitting nurse usually, or the team, and they would record all of the similar types of information in their own format in the facility. A week or two later, there will be a visiting assessor who will do a case mix assessment to determine payment. This is called the ANACC or ANAC, and that's a 75-item assessment schedule that captures information that's relevant to the cost of care. And sometime later, further data, another 60 or 70 items, are collected in order to calculate quality indicators to support the National Mandatory Quality Indicator Program. So over the course of a couple of months, this person would have passed through 5 assessment processes, all of which collect more or less the same data, similar content. However, the way in which the same phenomena, and would give the example of how much help a person needs to walk, would be done in a different way in each of these assessments. So 5 assessments, similar content, but minimal data conformity. And this is not what, at least my mantra and many others say, is collect once, use many times. In fact, it's an example of collect many times and use once. And that's counter to the idea of data efficiency and effective communication that we spoke about earlier. So each of these segments of assessment have been developed by different parts of the Department of Health, with advice from many others, of course. Each in its own right looks to be a sensible solution for that particular context, but taken as a whole, it's a bit of a mishmash of information that is not properly integrated across the passage of care for the older person. So this means a lot of data redundancy, inability to communicate accurately, and so forth. So we looked at this, we took the example of how to record how much help a person needs to walk. And we found that across these 5 assessments, this phenomena was scored in 6 different ways on 8 occasions across those 5 assessment events. So what are some of the other circumstances where information is collected in aged care in Australia? And I'm guessing there are equivalents to this in other jurisdictions. So in general practice, GPs have access and can offer what's called the 75+ assessment to older people. And this is essentially a comprehensive assessment that encompasses those phenomena I've listed there on the right-hand side. So what's their cardiovascular status? What are their meds? Are they continent? What immunisations have they had? What's their physical and psychological and social function look like? So that's a schedule of assessments essentially, and they get a particular payment to do that. And I think it's, for many older people, this is quite a beneficial opportunity to have their GP consider all of these things. Isn't this the same kind of information that would be used in a home care program? Wouldn't that be the sort of thing that you would record in a residential aged care program? Isn't this the sort of thing that you need to know about in order to work out how much to pay? So the answer is, of course, yes. All of these kind of programs, like the 75+ assessment, basically collect the same information, but they're all bespoke to these particular settings. Here's another example. So the Australian Digital Health Agency has thoughtfully produced what's called the Aged Care Transfer Summary, and this is addressing the problem of older people who live in a residential aged care setting going to hospital, and it's a frequent transition. So when they go to hospital, what information should go with them so that the hospital understands their needs? And again, when you look at the content of this, essentially it's the same kind of information. The problem with the aged care transfer summary is that the data relating to function, in that sense that I talked about a few slides ago, is not prescribed. It just says you've got to talk about cognitive function and so forth. So it's not lending itself to computerization if you don't have the data elements all standardized. Again, the Australian Institute of Health and Welfare has been commissioned to build an aged care national minimum data set. It has done quite a bit of work. It's got the, what I call demographics, age, marital status, languages spoken, that kind of basic demographic information is standardized, and information about episodes of care, when the person was admitted, this kind of thing, discharge information, so forth, not the care information. All of that is standardized, but in the middle, there's this care information, functional information, which has not been resolved in this aged care national minimum data set work to date. So there's a kind of similar to the aged care transfer summary, the functional information is not standardized. So there's a challenge there. And I've just earlier mentioned the integrated assessment tool for single assessment that's used by aged care assessment teams. That's operationalized yesterday. That does have standardized information, and I'll talk about how it's standardized in a moment. But it, as I said earlier, it's not compatible with any of these other kind of solutions. So what I'm showing to you is a whole lot of circumstances where attempts to standardize have been made and have only been partially successful. And what's more importantly, they don't use the same data ingredients where they do standardized across each setting, other than the basic demographics and transactional information. So, so what typically happens in many jurisdictions, in many organisations, in order to build a structured assessment system is organisations and the people within them basically get hold of these kind of what I call applications or scales, like the cognitive assessment module, cognitive assessment method for detecting delirium, or the pain scales, or mini mental state examination. These kind of things that that have been built by researchers and have been popularized as tools to identify risks or diagnoses, or to monitor progress. And basically you take them and you kind of put them together into a schedule, which is then standardized. And this is what we call a compilation assessment system. And this sounds like a pretty good idea. I mean, what's good about it is that each of these elements has probably had a fair bit of research behind it. It's everybody knows what it is that uses it. It comes up with a score usually, or a risk profile that everyone understands. So it's a logical way to build an assessment framework. So what's the problem with this? And quite apart from the fact that every organisation uses a different type of, some use the mini mental, some use a mocker, some use Rudash, others, Waterloo, and so forth. They use different versions of the same thing. So even when they do standardise, to some extent, they're using different standards. And this, amongst hospitals and programs, you see different variations of this. And so even though you've got standardised ingredients, you haven't got standardised assessments. So first of all, each one of these little tools tends to have its own bespoke way of describing things. So how mobility is described in each one of these tools, for example, is in the ADL scales versus the falls risk tools, or even the Waterloo, the way in which mobility is described is different. So effectively, if you did those three scales, falls, ADLs and Waterloo, you would already be recording mobility in three different ways. So what have you done? You've built duplication. And the other problem you've got is that even though you put all this together, it doesn't cover everything you need to know to provide care. So some stuff is missing, and that's not particularly helpful either. And then so to fill up the gaps, often what organisations do is they make up their own items, and they're often not trained in item design, and they don't test these items to see whether they're reliable. And so by that I mean they've got not very good psychometric properties. So you've got some good stuff and some ordinary stuff mixed up here. And then I've already made the point that different software solutions use different versions of these things, and so there's a lack of conformity. And what you find, at least in aged care, and I think to some extent in other care settings, software vendors are responsive to their purchases, in the sense that say, oh, you would like the mini mental in there. Okay, we'll program it up, and they produce a pick list of all these scales, and you can see in the software so many different versions, so many scales to pick from, and that doesn't necessarily then lend itself to a standardized approach within or among organizations. So some degree of standardization doesn't really fix the problem. So what are we going to do about this? And this is where I have some suggestions. So we wait till some organization decides that there's a standard like SNOMED. That's going to take years, because the work is not really evolving, even as I understand it. So this is where you produce kind of every phenomenon is described right down to the last molecule in the same way that SNOMED does it. What about finding another way to do this? And you could use the standardized compilation model that we've just talked about. So let's say in aged care, everybody uses the Barthel index to describe ADLs. Everyone uses the Waterlow to describe pressure, injury risk, and so forth. So you could do that, but it would come with all the problems that I've just talked about in the compilation model. Or one could select one of a number of integrated assessment models that are already out there. And I'll talk about that a little bit in the next couple of slides. So what is an integrated assessment model? And let me talk about that, and let me talk about how that could be aligned with emerging data standards. That is the SNOMED type of approach to recording information. So there are out there in the world about a dozen of these kind of systems that we describe in our world as second generation assessment systems. So instead of taking these kind of bits of the jigsaw and putting them together, essentially you go, right, what are the concepts that we want to record? Continence, mobility, cognitive function, mood, nutrition. Let's identify a way of describing these things that's relevant to the care that is always done in the same way. So, for example, mobility, how much help does the person need? 0 equals no help, 1 equals needs an aid, 2 equals needs supervision, 3 needs some minor assistance from a person. So in other words, you create a way of describing how much help a person needs in a standardized way using a set of design rules, and you end up going through the whole collection of phenomena that you're interested in, and you end up with the same information that you'd see in a compilation model, but you only record every phenomenon that's required once. So you don't have 3 versions of mobility, you have 1 version. And then you use that data to create the applications that you get with a compilation system. So using the data in that schedule, you can work out, say, falls risk, or you can work out pressure injury risk, or risk of undernutrition, or whether the person has dementia, and so forth. But you're always reusing the same data. So that's what these systems do. They're collections of data elements plus some tools that sit alongside them to interpret that data. But it's a very compact, collect once, use many times type approach to using the information. So what's the best of these? And we undertook an exercise, at least the staff in my organisation, at the instigation of the Aged Care Council IT, so the Aged Care Information and Technology Council commissioned my staff at UQ to do a thorough review of all these assessments. This was done last year. And what they came up with was the best of these systems is the Inter-Eye suite of assessment systems. And I wasn't involved in that review, but it convinced me that Inter-Eye is as good as or better than other solutions. So I have to say that I'm involved in the Inter-Eye effort internationally. For me, it's been a 20-year plus effort to contribute to building comprehensive assessment systems. I'm just going to spend a few minutes talking about how Inter-Eye has developed and is designed. It uses principles that would have come out of the discussions we've just had, and at least it's an example of how you could go about kind of sorting out the problems we've just enunciated. So, what, as I've just described a minute ago, there's a suite of clinical observations that are recorded by clinicians. Some of it's questions and answers to the older person, but mostly it's observations. And then there's a whole suite of applications derived from those clinical observations. So scales to measure severity, like an ADL scale. Screeners to identify problems and estimate risk. I've talked about those kind of things. What are the main needs of this person compared to everybody else? So how do you prioritize interventions? So do they need attention to their nutrition? Are they at particular risk of falling? Do they have a risk of pressure injury? Do they appear to be depressed, and so forth? So those are things you would want to see inside your care plan as priorities. And the system identifies people that have got those particular problems. Although we're having some interesting phenomena going on here. I'll just go back. And then there are this can be used to generate summary profiles, which is a quick way of understanding what the key observations are and what are the outputs. I did mention quality indicators and case mix tools. So this is a collect once, use many times exemplar. So you have one set of observations that generates all of that information for a particular individual. So the Inter-Eye long-term care facility assessment system has got a lot of items, 286. It sounds like a lot, but I would suggest you might want to walk into an RACF today and see how many observations are actually recorded one way or another. And whilst 20 years ago it would have been way less than 280, now it is way more. So this is actually quite a compact assessment system, and 286 observations is not a lot for somebody you're going to look after for 1 to 5 years. You really do need to know them well if you're going to have them living with you and you need to provide the care. 22 clinical protocols. This is suggestions for important aspects of the care. There are 14 prescribed scales, ADL scales and so forth, and it can generate up to 78 quality indicators. But remember, the protocols, the scales, and the indicators are all free of charge once you collect the 286 clinical observations. So this is what a form looks like, but of course this is all computerized. There's a lot of detail in there, but assessors learn how to score this very quickly once they've had their training. And these systems come with training manuals and with interpretation manuals, and so they're a very well-developed suite of tools to support clinicians. And of course, the advantage of all this, the data is robust, it's reliable, it's consistent, it's all been tested, so we know that. And so then governments get very interested in this kind of data because they can get it free of charge from clinical services to support their regulatory functions that we talked about earlier. So who uses these systems? Well, this is mandated in long-term care and in home care in Belgium, Canada, Finland, New Zealand, Singapore, Switzerland, and the USA, and many other jurisdictions in part are using parts of or in certain parts of the country using assessment systems. So these systems, I mentioned both the long-term care facility and home care systems, are widely used around the world. So anybody that uses these systems any country that uses these systems puts itself in a position to make comparisons with other countries that use the same systems. So this is the prevalent standardized assessment methodology in the world today. So I think probably enough for me to have talked about today. Just to summarize what we're saying is that standardized data is really essential for aged care, and we do have to kind of tackle this problem here in Australia like many other countries have. Secondly, there's no off-the-shelf terminology solution for critical aged care concepts, as there seems to be in acute care for the general healthcare system. Integrated assessment systems offer a first step towards data standardization, certainly a big step forward in terms of use of the data, in terms of all the stakeholders and how they might use standardized information. So, and I do want to mention that Indorite appears to be the best of breed of these available kind of systems. So, Georgie, I think that's my talk. Thank you for enabling me to talk about one of my pet subjects. I believe there's some questions, and Georgie and I will kind of try and address them in the remaining time.
Thank you, Professor Gray, for your presentation today. We do have some questions that have been collected through the Community Care Smart Assistive Technology Collaborative, so let's jump into it. First question is from Rachel in Far North Queensland. What are the primary challenges in implementing data standardization across different aged care facilities, and how can these be effectively addressed?
So I think there's a couple of problems here. One is lack of awareness about what is possible. I think a lot of decisions get made about recording information based on just local experience and also prevalent use of a lot of the scales that are pretty good, things like the Waterloo and so forth, that people just leap to that compilation solution straight away. Secondly, at a system level and actually at a provider level, huge investment in the past in these compilation type assessment systems. So the change is a big change. You really have to renovate your clinical information systems. So that means the software vendors have to change the way they present information. They have to build something like an Indorite system. That is a huge change and costs money and involves training and so forth. So it is a big investment to do that. Obviously, as soon as the investment's made, there's a big return on investment after that, but there's a big leap forward in order to implement these things. And the fact of the matter is, from what I've seen around the world, this won't happen unless the government or the regulator decides that it should happen. And the reason for that is that the regulator's always wanting information. As we know in aged care facilities in Australia, they want data for case mix and they want data for quality indicator calculation and so forth. So that tends to drive the behaviour of providers, and therefore without the government saying, yes, we would like our information in Indorite format, or we expect you to use an Indorite assessment, and from that we'll get the information we require. Unless that decision's made by the regulator, it's almost impossible for a provider to use anything other than its own made-up system, and that gets combined with what they have to report to the regulator. So it's a pretty messy situation we have at the moment. So that's the problem, and also the data demands tend to be coming from different components in the Department of Aged Care. They don't appear to have a comprehensive view about the data standardisation problem at this time, although I don't think that's entirely a fair comment, but that's been the problem in the past. So how do we deal with this? Well, we have to get a collective view of what the solution is, and we have to come to a view that we do need to standardise, and then a significant investment is needed to make the transition, after which it's just savings and efficiency. But there is a big barrier to be jumped over in order to make this happen. I think that's enough on that topic, Georgie.
Thanks, Professor Gray. Next question is from Bill in country Victoria. How can aged care providers ensure that their data standardisation efforts are aligned with regulatory requirements and industry best practice?
Well, that's the kind of $64 question, isn't it? And it's a very difficult problem that aged care providers have, and obviously they've got software vendors so that support them. So they've got to get their software vendor to do what they want, and then they have to make sure that their data efforts are aligned with the government. Well, the government's requirements are complex and not standardized, and so it's very, very difficult to take the initiative without the government's kind of blessing, if you like. So I don't think it's really possible to solve this problem at the provider level without a system-wide agreement about how it should be solved. That sounds a bit negative, but on the other hand, I am aware that there is growing awareness that this problem needs fixing and that an investment needs to be made, and then we should all do this together. Thanks, Georgie.
Thanks, Professor. Next question comes from David in Central Perth. What are some of the best practices for engaging stakeholders, e.g. healthcare providers, IT professionals and policymakers to support and adopt data standardisation in aged care?
Well, that's a really good question, and if he's got the answer, I'd love to hear it. But for our part, we're obviously from my part, data standardisation aligned with some kind of data standard, is absolutely critical. Obviously, I would suggest that InterEye is a pretty good way of solving that, but there are other ways of doing it. So I think those of us who are aware are really advocating for this solution. I think I've been thinking about this for a long time, but I think the pressure is there to do something now because we're collecting many times and using very little. And I think that's driving a lot of data inefficiency and huge pressure, particularly within residential care, but it'll come to community care before we know it. That means something's got to be done. And I think that's really the big issue. But awareness is really important, and that's part of what I'm doing by giving these kind of talks, but others are on the same mission. Yes, Georgie.
Thanks, Professor. The last question before we have to wrap up is from Judy in Southeast Queensland. Would this approach cover other areas such as community services and disability areas? Absolutely, yes. And of course. And one thing I haven't really emphasised about InterEye, but any kind of assessment system like the InterEye system, what InterEye does, its home care and long-term care systems share the same information recorded in the same way. So the home care version will record continence, mobility, cognitive function, mood, nutrition, everything looks exactly the same as the residential care assessment. There are some additional observations that are only relevant to home care or only relevant to residential care. And, for example, how many steps to get into the house is an important observation to be made in a home care setting, but not particularly relevant to a residential aged care facility where you would hope there would be no steps to get into the building. But so you do have some variation. So InterEye is built about
25 systems across the age spectrum that share the same way of recording these phenomena. So it starts with children, adolescents, adults, disability services, everything. Intereyes kind of done everything using the same methodology, and wherever possible using the same way of recording information, and wherever relevant using the same scales. So that's why Intereyes describes itself as having a suite of assessment systems, an integrated suite. And whatever one does, one would want to use the same data solutions in every setting for the same reasons that you want them consistent within the setting. So that's the lessons apply across the settings as much as they apply within the settings, of course.
Thanks, Professor. That's all the time we have now for questions. So thank you so much for your presentation and for answering the questions from the collaborative. We will be posting today's webinar on the Community Care Smart Assistive Technology Collaborative. So if you haven't already done so, please go online and register. You will also be able to gain access to hundreds of resources, exclusive events and forums on assistive technology and innovation in community care. If you have any further questions or inquiries, please email us at sat@communityresourcing.com.au. Once again, I would like to thank the members of the collaborative research team and today's guest speaker, Professor Gray. Thank you everyone for attending today's session, and we look forward to seeing you in the future.